Very good. Thank you, Bevan and Nigel, for the privilege of participating in what I anticipate will be a spirited debate about novel surgical treatments. And I will focus my comments around remote access thyroidectomy, which will come as no surprise to many of you in the room, with maybe a little bit about maxillary removal and reinsertion. First, my disclosures. I've directed a series of thyroid courses sponsored by Johnson & Johnson. I've received royalties from 4 endocrine books. I'll marginally discuss the surgical robot, which is approved for general surgical applications. The company doesn't currently support axillary thyroidectomy. I have some additional disclosures. I'm a shameless advocate for personalized medicine. In fact, my institution was a pioneer in patient and family-centered care, and this banner hangs in our lobby. And to me, that is largely what motivates my innovation and my efforts to provide personalized care for my patients. Which brings me to what this debate is really about, because to me, it's not so much about the robot or other surgical technologies. These are just tools to accomplish a surgical objective. It's not even really about the money. And when you think about Dr. Foho's lecture this morning at $100,000 a year for chemotherapy, we're talking about a tiny fraction of the trillions of dollars in healthcare expenditures annually in the US. It's more about patient choice, and it's more about enabling innovation, and ultimately the question, should we offer innovative approaches for selected patients, or must we insist that everyone have their surgery done exactly the same way? And so we all know there have been some senior colleagues that have been critical of alternative approaches to thyroidectomy, including my very worthy debate opponent, Dr. Schuler, who wonders why are modifications to standard approaches occurring? And I would say this is a different era. The days of the paternalistic physician approach are largely in the past, and the Norman Rockwell depiction of the country doctor has given way to a very sophisticated patient population with the internet at their fingertips, and they're as likely to have their healthcare questions answered by Google as they are by their physicians. So therefore, medical decision-making now necessarily involves the patients themselves, so we must respect our patient biases, we must acknowledge our patient fears, we must understand our patients' concerns rather than imposing our own biases on our patients. And I would venture to guess that the 3 individuals pictured here don't care very much about a thyroid scar, for example, but that's not a thyroid patient population. The thyroid patient population does care about a scar, and sometimes very deeply. Which brings us to quality of life measures. And I don't know much about qualities, and this is not my area of expertise. It's thyroid surgery is my area of expertise. But I can tell you that we know about quality of life measures, and they come in all different flavors. And if you're talking about a head and neck cancer patient who's worried about dying of their disease, and we hear compelling stories like Michael Douglas's story, we can now start to think about quality of life, like things like swallowing and speech and breathing, and where am I going to be breathing out of? It's different for thyroid and parathyroid patients. They have non-life-threatening conditions. So we have the luxury of thinking about other things like maybe, I don't know, scar or body image. Yeah, this is new to me too, but there was a paper that just came out 2 months ago in Surgery from South Korea focusing on body image and comparing open thyroidectomy to remote access thyroidectomy, and domains that I was unfamiliar with, but things like feeling less feminine, dissatisfaction with body, scar, and appearance, and avoidance of people due to appearance, and no surprise, the remote access patients scored higher on all of the domains. Another interesting paper also this year out of Herb Chen's group in Wisconsin, looking at patient preferences, and they looked at an unselected population of individuals at the mall to see what their preferences were regarding if they needed to have thyroid surgery. 89% judged scar to be important or very important. I was surprised 82% preferred remote access surgery, and this is men and women. But more impressive to me was the fact that greater than 50% preferred remote access surgery even if they knew that their complication rate was going to be quadrupled. 20% wanted remote access surgery even if they knew their cancer might not be cured. 16% were willing to pony up more than $5,000 for the privilege of having remote access surgery. So I found these astonishing. And imagine that the proportions would be much higher in our target population rather than an unselected population. So we all know that there are gender considerations when it comes to thyroid surgery. What I didn't know is that my debate opponent, his early investigation related to women's issues. You probably didn't know this either. I think this is Dr. Schuler's very first publication as a medical student, published in the Ohio State Journal of Medicine, where he explored the influence of women's magazines on public opinion, interestingly. So I'm pleased that he's sensitive to these issues. And I hope he will agree with me that we want to customize our surgery to the patient and their disease characteristics as opposed to one size fits all. I mean, and to me, this is an exceptionally important principle in modern thyroid surgery. So for example, should this patient with a 2-centimeter indeterminate nodule have the same operation as this gentleman with a goiter the size of a small child? And I know many of you will say, well, if you make the incision and it's skin crease and my incisions heal well, yeah, and you can get very good results, especially with minimally invasive techniques, but not always. And so even with a small, low incision, depending on the skin type, you may get a bad hypertrophic scar in a very public location. And that has been part of the motivation of these remote access techniques, starting in Asia with this axillary approach. And we have these other crazy approaches. We got the breast approach, and I just saw these live in Shanghai a month ago. We got the BABA approach, bilateral axillary, bilateral breast approach. Even transoral surgery is being done in Germany and Asia. And my friend Ashok Shaha has talked many times about a transrectal thyroidectomy. I don't think he's done any. I don't think he's done any in patients yet. It must still be in animal trials. But in seriousness, now more than 20,000 remote access thyroidectomies have been accomplished worldwide, and every report demonstrates them to be comparable in terms of effectiveness and safety. More than 1,000 in the US. Is it more costly? Yes, slightly, related to the duration of the surgery predominantly. There have been other innovative surgeons and other innovative techniques. And once again, I was pleased to discover that Dr. Schuler himself has been an important innovator, and this was a presentation he made in Hawaii in 1991, and I was there for it. Maxillary removal and reinsertion for accessing the skull base. Interestingly, he was criticized, you may remember this, for using a facial degloving approach rather than the traditional lateral rhinotomy. I can only presume that that was for aesthetic and cosmetic reasons that you would do that, and it was pointed out to him that you may risk leaving behind tumor with that approach. But I applaud him for looking longitudinally at his outcomes. 18 years later, there's 78 patients, no intraoperative mortality, 62% survival rate after 5 years, so undoubtedly has substantially helped his patients. For anybody considering pursuing new procedure development, I think it needs to be systematic. So we want to conceive of the idea, of course, that must have a definable advantage, and that can be lots of things. It can be no neck scar, it can be faster surgery, maybe less invasive surgery, but something. If you can start with simulation, so much the better. That's often challenging to do. Sometimes animal models can be helpful, particularly cadaver models, I think, are very useful. And cautious clinical implementation with or without the endorsement of an IRB, depending on how different it is from existing techniques. And so we've tried to do that when we have innovated. And most recently, it was the robotic facelift thyroidectomy we introduced 3 or 4 years ago. And we started with animal investigations to define the proper vector of approach to the thyroid compartment. Then it was cadaver dissections to help elucidate the proper planes of dissection and the best instrumentation. Then it was a small group of patients where we did clinical implementation to demonstrate the feasibility and safety. Then it was focus on patient selection criteria. then back to the cadaver lab to better refine and define the landmarks which can make the procedure more efficient. Armed with that information, a focused paper on specifically the operative techniques, then comparison to the existing alternative, which is axillary thyroid surgery, and then video endoscopic documentation for those most interested in potentially acquiring this skill set. And then finally, properly positioning this approach with other alternative techniques. I think it's appropriate to question the motivation for innovation, and whether you're innovating yourself or doing somebody else's innovative procedure, are you doing it for practice building purposes? Is it marketing? And we've all seen the airline magazine ads for various procedures. Are there financial motivations? For example, and not to pick on our South Korean colleagues, but it's interesting that their health insurance system motivates high technology procedures. They get paid 4 times as much for doing a robotic thyroidectomy as they do for open surgery. Here in the US, we get paid the same no matter how we do it. So let me just close with a few remarks. Most patients should not have remote access thyroid surgery. And in fact, most surgeons should not perform remote access thyroid surgery. My limited time didn't allow me to get into that issue of it should be high volume surgeons, high volume centers. But let's not deprive appropriate individuals from having the best surgery for them. Thank you very much.